Okay, class, I'm just going to talk about these additional respiratory problems that you might encounter with some of your patients. All I expect you to understand is just the basic etiology of what kind of a disease process this is, and whether or not there's any specific treatments and any specific nursing intervention that goes with this particular respiratory problem. The first one here on the PowerPoint slide is interstitial pulmonary disease. And this is just any problem that affects the tissue and space around the air sacs of the lung. The important thing to remember about this disease is it's more of a restrictive disease. We had been talking prior about all the obstructive disease. This is a restrictive disease where you have progressive scarring of lung tissue, and the lung becomes very thickened, reduced gas exchange, and it gets very stiff, so the lungs don't expand well, and that's what makes it a restrictive disease. It's a very slow onset of the disease. Obviously, dyspnea is the most common manifestation, often present with a lot of patients that have like a rheumatoid arthritis or a scleroderma. Those primary alveoli wall structures mostly primarily affects the alveolar wall structures, but it can also involve the small airways and blood vessels. Okay, so that's all that is. Okay, and think about interstitial. Has to do with, when you talk about interstitial space, it's the space between the area around the air sacs of the lung. Okay, this next one, you've probably heard this in the news. You see people that get sarcoidosis, more of a granulomatosis disorder of unknown cause that affects the lungs most often. Alveolar inflammation, more of a fibrosis, scarring in the tissues, lung compliance, involves the lungs, lymph glands. There's like abnormal masses or nodules that occur. More of an autoimmune response in which the normally protective T lymphocytes increase and damage lung tissues. Really, like I said before, an unknown cause. Growths can occur in the lungs, the lymph nodes, even in the eyes and the skin. We see this a lot in young adults, more of a granuloma growths that contain these lymphocytes and macrophages and epithelia cells. Corticosteroids are the main type of therapy just to kind of reduce that inflammation. Anything with an autoimmune, usually we see corticosteroids as one of the treatments with drugs. The next one is idiopathic pulmonary fibrosis. This is another type of restricted lung disease. People that have viral infections can be at risk of acquiring a pulmonary fibrosis, even smoking, sometimes genetics, and they're even seeing with some of the research that it can also be related to somebody that has GERDs. Really no cure. You see thick and scarred tissue, inflammation that goes beyond the normal healing time causes extensive fibrosis and scarring. Again, some of the treatments are corticosteroids and other immunosuppressants. Usually the prognosis once someone's been diagnosed with this is less than 5 years. A lot of coughing, shortness of breath, a lot of exercise intolerance. Severity of the symptoms with somebody with pulmonary fibrosis kind of vary from person to person. Another cause can be by environmental pollutants, even certain meds, such as like chemo meds, when people are on those for a lengthy period of time due to some kind of cancers. Even some of antibiotics, some cardiac meds like amiodarone. So that's pretty much what pulmonary fibrosis is. Many of these patients during the, as it becomes more progressive, usually need to be on some type of oxygen therapy. Occupational pulmonary disease is just what the title says. It can be caused by exposure to occupational or environmental fumes, dust, vapors, gases, bacterial, fungi, antigens, or allergies. Black lung, more of an irritant-induced asthma, allergic asthma, even silicosis caused by silica dust. People that years ago we didn't know all the hazards when people worked like in the coal mines, and they were exposed to these types of irritants and really developed some very severe pulmonary disease. If they smoked, obviously the disease progressed faster and was very much worsened by cigarette smoke. And now we know a lot more about these type of irritants, and when people are exposed to these type of environmental contaminants or pollutants, we really advise special respirators and adequate ventilation to protect the lungs from any kind of serious injury. And the last one that I'm going to talk about, not a whole lot, because we'll touch on this a little bit more in detail when we get to hematology and oncology, is lung cancer. We're still seeing this is the leading cause of cancer deaths worldwide. Obviously, one of the most important ways to prevent from acquiring lung cancer is through smoking cessation. And as we take care of patients who do have lung cancer, we kind of look at the subjective data that concerns that, and we look for people who smoke, what their occupation is. They have the history of hoarseness, cough, sputum production, hemoptysis, shortness of breath, and decreased activity endurance. And then we do look at those objective assessment findings and look for a cough and listen to their lungs. Are there wheezes? Do they have a fever? Sputum, hemoptysis, and chest pain. The sad thing about lung cancer is that the majority of the lung cancers that are diagnosed occur after the disease has spread, and the 5-year survival rate for lung cancer is only about 14-15%. These statistics can tell you that many patients will be diagnosed with lung cancer, and you will be caring for them during your career. Over 90% of pulmonary tumors are malignant, meaning they are cancerous. Almost all are bronchiogenic, meaning that they begin in the tissues of the bronchial tree. And lung cancer is the #1 cause of cancer-related deaths in the United States among men, and the second #2 cause among women. The peak incidence occurs in those between the ages of 45 and 75, and it's twice as common among males than females. The majority of lung cancers occur because people smoke. People that smoke have about a 20% higher risk of developing lung cancers as non-smokers. But there's other risk factors too, maybe being around certain irritants such as asbestos or radioactive particles. The most common early symptoms is a cough, and but it isn't a true diagnosis. These symptoms are really not the most effective way to diagnose it. Usually chest x-rays are recommended in patients that might be a high risk of developing lung cancer. Usually what they'll do is a bronchoscopy and a biopsy is another important diagnostic tool after a chest x-ray, because the chest x-ray may reveal the tumor, and we need to be sure and kind of look at what kind of cells we're dealing with. And so they might also do a sputum for cytology is a good test because it may reveal a positive result before symptoms are noted. Since the most common sites for cancer of the lungs, they spread a lot to the adrenal glands, the colon, the kidneys, and the bone marrow and brain. And so a lot of times they'll do PET scans and other further MRIs and CAT scans to determine if the tumor has spread to other organs in the body. Usually when they do diagnose a cancerous tumor, they'll want to do surgery and remove that portion of the lung or parts of the lung or the whole lung possibly, depending on the extent of the tumor. The surgery may involve removal of just the tumor, removal of a segment of the lung, removal of a lobe of the lung. We call that lobectomy. Or if they remove the entire lung, we would call that a pneumonectomy. So really a poor long-term survival because of the late-stage diagnosis. As I said, most of them occur in the bronchiogenic areas, in the bronchioles. They'll stage it to assess the size and the extent of the disease and kind of look at a person's history to determine if they probably do have lung cancer. It's a very scary time for people when they may suspect maybe they do have a cough, but they kind of say that it's maybe due to the fact that they do smoke. But when people start coughing up blood or they start to lose weight for no reason at all, that could be an indication of some of the late types of symptoms. They may use chemo, targeted therapy, radiation therapy, and photodynamic therapy. And I'll talk a little bit more about this when we get to oncology with our hematology lecture. And these are some of the types of surgical managements that they may do for a patient. Like I said, this is all dependent on the patient's, when they were diagnosed and to the extent of the tumor. And sometimes some of these cells are very fast growing, and they want to get that particular cancer out of the system right away. They may do just a lung lobectomy, meaning just taking out just the lobe, or take out the whole lung, which we call a pneumonectomy, or do a segmentectomy or a wedge resection. All these patients usually go to ICU overnight just to watch for any types of respiratory distress or infection or bleeding. And this is where they usually make the incision for a partial or total pneumonectomy, but obviously it's surgeon preference, okay? If they are going to just do a lobe and they've left part of the lung in, the patient will have chest tubes to reinflate that lung, and you'll get a lot of the learning and knowledge about chest tubes in your lab in week 2, and so please, I hope you understand that, because you may see some questions regarding chest tubes on your respiratory test. Just shows you where they might place the chest tubes, because sometimes a patient may have 2, and one is to reinflate the lung, and the other purpose of the chest tube is to drain out all that blood or fluid that happens during surgery. And I'm not going to get into this, but it's just a summary of the different chambers with our chest tubes, chamber 1, 2, and 3. And like I said, you'll get this all in your lab in week 2. This is just a picture of the chest tube drainage system and what are responsibilities for patients who have a thoracotomy. Obviously, pain is one, respiratory management, and depending on whether or not the patient had part or the whole lung removed, okay? And these might be some interventions we might provide our patients who are receiving palliative care for lung cancer, oxygen therapy, drug therapy, radiation therapy, might do a thoracentesis or a pleurodesis. We talked about thoracentesis early on in our assessment lecture. Some of these patients do tend to build up a lot of fluid in the pleural space and really start to develop more shortness of breath and dyspnea, and need to have maybe reoccurring and frequent thoracentesis is done. A lot of them are referred to hospice if it's end-stage type of tumor, and just to control any type of pain or respiratory distress these patients may encounter in the later stages of the cancer development. And that concludes this chapter on non-infectious lower respiratory problems. So continue to watch these videos and use those study guides as a means to kind of think about what you took away from the lecture as well as what you're reading in your books. I want you to understand this stuff very well. So it might take repetition, going over the reading, looking over these study guides to say how much do I remember from the lecture as well as what do I remember from the reading. And like I said, please ask me any questions you may have, something that may have not been clear to you, because I really want you to get a good understanding of this information. Thank you and have a great weekend.